Hello, welcome to episode 160 of the Inside Knowledge podcast. I'm Anna Mapson. Hello, today I'm so pleased to welcome Clemmie Oliver, who's an IBD specialist nutritionist, and she also has her own clinic called Nutrition and Lifestyle Medicine Clinic, which supports people living with inflammatory bowel disease, including Crohn's, ulcerative colitis. And so she works with people liaising with their medical team, helping them with symptoms and diet. And she's also has IBD herself. So she's got a really compassionate understanding of the kinds of things people suffer with when you've got IBD. But today we're really talking about the difference between IBS and IBD, like what even is IBD? How would you know you've got it? What's the diagnosis process? And so how does it differ from your standard IBS? And we cover in there the fact that the acronyms are so similar, which makes it ultra confusing. But she's really clear. She's got a really great way of explaining things. So I think you will find this episode useful. Hello, welcome, Clemmie. So lovely to have you here.
Thank you for having me.
So I thought we could maybe start just with a little overview of your practice, what kind of work you do, the kind of people you see.
Yeah, sure. So I run a clinic called the Nutrition and Lifestyle Medicine Clinic, and it is a clinic dedicated to supporting patients with inflammatory bowel diseases. And that can be someone who's newly diagnosed to someone who's been living with the diseases for a long time. But also we do pre-surgery and post-surgery support for people. So work with people with J pouches and stomas as well. So we cover the full suite. And I also, as well as my one-to-one clinic role, I work doing freelance and consultancy work for various IBD charities and things like IBD companies, stoma care brands, that kind of stuff too.
Amazing. And did you say there's a team of you as well? How many people work at your clinic?
So we're a small team. We're two of us. So there's myself and my lovely dietitian, Jess, who works with me. And she works with me on projects behind the scenes at the moment.
Great. Lovely. All right. So, maybe we can just start out, as everyone listening to this has got IBS or think they might have. But I wanted to talk about this today just to really differentiate a little bit around what is IBD, what is IBS, because I think people get quite confused. Obviously, the acronym's similar, which doesn't help, but also in terms of some of the symptoms can also have a real overlap as well. So it can be quite confusing. So, maybe you can start off just explaining a bit about what is inflammatory bowel disease.
Yeah, absolutely. And you're so right. I think that so many people I see get so confused because the acronyms are the same and loads of the symptoms overlap. So, but IBD stands for inflammatory bowel disease, and it's an umbrella term for a small group of chronic lifelong conditions that cause inflammation or basically swelling of the digestive tract. And there's kind of two main ones and then another one. So we've got Crohn's disease, which can affect anyone all the way from their mouth all the way through down to their bottom. We've got ulcerative colitis, which only affects the last part of the digestive tract, so the colon. And then we've got another one which is less common, but is quite often underdiagnosed or misdiagnosed in IBS, and that's called microscopic colitis.
And do they all appear with the same kind of symptoms? Like, how would people differentiate it? Or is it only via diagnosis that you would understand if it's different parts of your body?
Yeah, no, really good question. So some of the symptoms do overlap with IBS. So things like diarrhea, constipation, bloating, pain. But the differentiating symptoms in IBD are that someone might experience, particularly with ulcerative colitis, they might experience blood when they're passing a poo, when they go for a poo. Or that might be on wiping, that might be blood in the bowl as well. And also weight loss is one of the symptoms that we often see when someone before diagnosis and also during the disease. So there are two things to really look out for. So unexplained weight loss and bleeding when you go to the loo. Bleeding doesn't happen in everyone though. So in Crohn's disease, if it affects the digestive tract higher up, sometimes you don't get bleeding. So that's when we look at things like pain and unexplained weight loss. And that's when we would look to have some other investigations to see if it might be IBD. So we've got some really important kind of distinguishing features that aren't IBS, like the bleeding and the weight loss, which we would normally see in IBD more than we might see in IBS.
And the bleeding, is it all fresh red blood? And like, does it have to be a lot? Because obviously some people have hemorrhoids, and people are surprised perhaps that you can get hemorrhoids with diarrhea as well, not just from straining and constipation, but that can also have bleeding, can't it? So how, if someone saw blood, they wouldn't necessarily automatically assume IBD, but yeah, does it a lot of blood that they would have to see?
Yeah, it can vary in amounts. And I think what's just really important to do is, if you experience any bleeding from your bottom, to go to your GP and to talk about it. And probably it's nothing to worry about. But on the occasion, it might be, and the sooner you can get diagnosed, the better. So whatever that might be, if it's IBD, though, we know that people who have IBD, that the earlier they're diagnosed and the earlier they get on treatment, the better their chances are in terms of their disease course going forwards. So if you have any kind of bleeding from your bottom, it's really good to get that checked out. And as you say, that it might be hemorrhoids and it might be something like that, and it might be just nothing to worry about. But we just want to make sure that we're ruling out any of those more serious conditions before just discounting it.
Yeah, brilliant. Okay. And what about the diagnosis process? So you mentioned like inflammation, that's one of the key differentiators. How is that measured for people?
Yeah, absolutely. So if I kind of talk you through, I guess, like a route that someone might take. So someone might be experiencing some weight loss and some pain, and maybe they've noticed bleeding when they go for a poo. They should, first of all, they should book in an appointment to see their GP. And then they should go to their GP and they should explain these symptoms that they're experiencing, and particularly saying that they're experiencing blood, or that they're experiencing unexplained weight loss where that they haven't been trying to achieve. And then what a GP would normally do is they would run some blood tests. And they would look for inflammation in those blood markers. So something called CRP or ESR. And then they would also perhaps get you to do a stool test. So that's basically like a poop in a pot. And then that gets sent off to the laboratory, and they look for an inflammatory marker in the stool. It's called fecal calprotectin, but you don't need to remember that. But just basically shows, like, is there any inflammation in the stool that's coming out, which will correlate with inflammation in the bowel. If that comes back kind of raised a bit, they might want to repeat that about 6 weeks later. But if it comes back raised a lot, so over about 250, then normally you would then be referred to the hospital, to a team called the gastroenterology team. And when you get there and you get an appointment there, they will discuss your symptoms, and then they may want to have a look inside your bowels with a little camera. So it's basically like a really thin hose pipe that they put into your bottom, and then they just have a look at what's going on inside. And I know all of that sounds quite unpleasant, but it is really important to have that done, to just check what's going on and to help with the diagnosis process. And what they do as well is they look with a camera to see the lining of the bowel. And they sometimes take some little biopsies, so little bits of tissue from the inside of your bowel that they can then look at under a microscope to see, is there any inflammation? If so, what does that look like? And that's the gold standard. So that's like the way that you can diagnose IBD, is the scope and the biopsies. And if it's Crohn's disease, or if they want to rule out Crohn's disease, you may also have to have something called an MRI scan, which basically just looks at the small intestine as well. And so those kind of first blood tests at the GP and the stool test, that can't actually diagnose IBD, but it will indicate what pathway the GP needs to send you on for your next steps.
Great. Yeah. So it's like the screening to see, do you need to get into the process? And do you know how long roughly it takes? Like how long people might have unexplained symptoms for. I think I read for celiac disease, it's something on average like 13 years, or it can be. So is it a long process for people as well, going back and forth to the GP, trying to work this out, having lots of tests?
It can be a lengthy process. I think it's kind of a little bit with that, like how long's a piece of string? It depends on how long the person's been having symptoms and how long it's taking them to go to the GP. What we see, and I can't remember the stats off the top of my head, but it takes women longer to get diagnosed than men, which is often the case with quite a lot of medical issues. So I think it's sometimes around about a year for women and about 8 months for men. But that will really vary depending on when you go and get looked at, what your symptoms are like, what your test results are showing, and then like where you are in terms of location in your hospital and how long the waiting lists are for someone to be seen in the gastroenterology team.
Yeah, it's such a potluck sometimes, unfortunately, isn't
Yeah,
it?
it's such and it's a difficult system at the moment that we're dealing with lots and lots of delays, which isn't very helpful when you are worried that you're getting these symptoms and maybe your symptoms are getting worse and worse and you're really not feeling very well. And it's really hard then to have to wait to get the diagnosis.
Yeah, and also I suppose if you're thinking every time you're eating, it's maybe making the symptoms worse, you're like worried about the pain increasing as well, so that sort of the longer it goes on, then the chance of nutritional deficiencies increases.
Yeah, definitely. And I think perhaps we'll come on to this a little bit later, but I think the really important thing to understand with IBD is that although when you eat, the active eating might make you go to the loo and make your symptoms feel bad. Food in itself doesn't cause inflammation in IBD, and food in itself isn't going to worsen the disease. It's just that when food enters the system and then it causes food that you ate before to move along the system, that's going to cause pain and discomfort and symptoms, but it's not the food itself that's causing any damage to you.
And it's not necessarily increasing the inflammation markers then. So it's more about the disease process, or rather than that's what's increasing the markers. I think that's what people worry about a lot, isn't it? Like you're damaging yourself, making things worse.
Totally.
And certain foods are like exacerbating it. Could they be exacerbating the pain though, or making the symptoms worse, even if they don't progress the inflammation?
Yeah, definitely. So as much as food can't increase the inflammation or make it worse, actually there are things that we can do to adapt a diet to help make it better tolerated during a flare, and perhaps we'll cover that a little bit later in terms of kind of adaptations and dietary approaches for IBD. But there's certainly things that we can do to help to reduce your symptoms and actually help to manage your symptoms if you're on an IBD flare or when you're in remission as well. Food's a really, really important part of managing symptoms, helping to support your gut health and your gut microbiome, and hopefully helping you to achieve long periods of remission when you do get the diagnosis and beyond.
Yeah, and what about the medical management then as well? So there's lots of different things that people can take to try and help with that reduction in inflammation.
Yeah, absolutely. So there are, depending on the disease, so we've got Crohn's, ulcerative colitis, and then microscopic colitis. There's different treatment approaches. Some of the Crohn's and ulcerative colitis won't overlap. So we've got kind of a first tier of medication for ulcerative colitis, which is called mesalazine, and that's often prescribed as a first step for patients. Patients might also, if they go to the GP and the gastroenterology team and they're in quite a bad flare, they might be given steroids for 8 weeks just to help to rapidly reduce the inflammation for them and get them feeling better. And also then perhaps while they're starting on another treatment option. There's also immune suppressing medications, something called azathioprine, methotrexate, a couple of different ones. And they work on generally suppressing the entire immune system. And then the next one that we've got is something called biologic medications. So they usually end in a MAB, so vedolizumab, and lots of different ones. I don't know why they give them such complicated names because no one can ever remember them. But they are immune modulating medications. So they target really, really specific molecules in the immune system that we know that drive inflammation in IBD. what we're seeing more and more is sometimes patients, depending on the severity of their disease, going straight up to the biologic medications. And they can be really, really effective. And what I tend to see is, I think there's a lot of misinformation online around IBD and the management, and there are a certain number of patients, a small number of patients, who may be able to manage their disease through diet alone, but the majority of patients will have to take some kind of medication to help to manage the condition. It's very much, I talk to patients a lot about pieces of the puzzle when I'm talking about managing a condition like IBD. So if you just take one piece, you don't get the complete picture of care. So if you just look at medication and don't look at diet and exercise and sleep and stress, then you're missing the complete picture of care. But again, also, if you're only focusing on diet and you're missing the medication, again, you don't get the complete picture. So the complete picture is when you bring all of those pieces together. And that means that you're covering all the bases that we know can influence the disease and can influence symptoms as well. So generally, I see that medication forms quite a central piece of the puzzle in IBD care for patients. And that's quite an important part of the journey.
And do you have to take it forever? Like some things you'd be on constantly for the rest of your life?
Yeah, so again, it depends. If you have mild inflammation or inflammation just in the rectum in ulcerative colitis, you might be told to take suppositories. So things that you just put in your bottom, tablets that you put in your bottom, and then maybe you only take those whilst you've got the disease, as in whilst you're in a flare. So I guess I should have said at the beginning that with IBD, the disease, you go through periods of flare or relapse where the inflammation is active and the disease and the symptoms are active, and then you go through periods of remission where essentially the disease is asleep and there's no inflammation there, and hopefully your symptoms and should be well controlled and you should be able to live your life quite normally.
Although I guess some people don't want to take medication, I work with a lot of people where there's no real driver or cause for their symptoms. It's just IBS, it gets told. And actually some people almost feel a bit disappointed when they don't get a diagnosis of something like this, because there is a treatment pathway and it means you're like in the system and someone knows what you've got and how to treat it. And actually, although it's in some ways worse and that, it's something you might have to be on medication for the rest of your life, but actually it can be a bit of a relief to have someone sort of take it on and manage it for you, which you don't always get with IBS. So even though it's not necessarily something you'd wish to have as a diagnosis, at least there is a treatment pathway.
Yeah, I think that can be right sometimes for patients. I think lots of patients go for quite a long time not knowing where their symptoms are coming from. Lots of patients that I see may have presented to their GP and been put on the cancer referral pathway, and then have this horrible panic for a few weeks whilst they have those tests done, thinking that they might have cancer, and that's so distressing. So to get a diagnosis that's not cancer is often a good one, but to get a diagnosis that's IBD, it's a life-changing thing, and there's a lot to get your head around there. And I guess, again, in terms of the similarities and differences in terms of IBS, so they're both can be lifelong conditions. IBD is definitely a lifelong condition. And with IBS, the symptoms are, it's very debilitating as a condition. It can be really life-changing for people, but it doesn't lead to any more serious complications. Whereas IBD, you have an increased risk of bowel cancer, not in microscopic colitis, but in Crohn's and colitis and ulcerative colitis. And you also have a risk of having to have surgery, so having to have parts of your bowel removed. So in Crohn's disease, it's up to about 50 to 80% of patients will require surgery at some point in their life to remove a section or parts of their bowel. And in ulcerative colitis, I think it's around 20 to 30% of patients will have to have their colon removed at some point, and that will result in having something called an ileostomy, which is when they pull the last part of the small intestine out through the abdominal wall, and then you have a bag that collects the waste on the outside. So, and those kind of things can be like super life-changing for people. And it's really important to remember, though, I don't want to scare people, but like that's not, like, lots of patients manage very well and don't have to have those surgeries, but it is a risk in some patients.
What would be the big changes in terms of people's lifestyle or diets once you have a stoma or ileostomy bag or something, what are the sort of changes for people's life that they could expect?
Yeah, sure. I mean, it takes a bit of adjustment, and you'll be advised if you have stoma surgery, you'll be advised to follow a low fiber diet for about 6 weeks or so. And that's to allow the bowel to heal. There's lots of swelling in there. It's difficult for food to pass through, and you just want everything to be nice and easy with not lots of big particle sized things trying to get through a swollen bowel for a bit. But as things settle down, actually, again, there's lots of misinformation about this, but and everyone will have their different things that they find work and don't work for them. But generally, once you've been through that period of time, post-surgery, then you should be able to, over time, return back to a normal, healthy, balanced diet, what you used to eat before, and to do a lot of the things that you used to have before. So it is very much a life-changing, it's very much life-changing surgery. But there is also life after surgery. And I say that as a health professional who works with these patients every day, but I also say it from a patient myself, who lived with an ileostomy for 7 years.
Right. But you don't have it now. So you mean it's a temporary thing?
It can be temporary. So you can basically get your plumbing reconnected. It doesn't work quite the same way, but it means that you don't have to have the bag anymore. Yeah. But I feel like we've gone on a bit of a tangent, haven't we? So. Yeah.
I was going to ask as well, what are the sort of risk factors? How could it start in people, or who might be more at risk of IBD?
Yeah, sure. So if you have a relative who has Crohn's or colitis, then you're more likely to get it yourself. Although it's not just because you have a relative who has it that you'll definitely get it. Again, the exact stats, but it's in the kind of low numbers. So I think it's about like around 3 or 4% for ulcerative colitis, and it's a little bit higher, like 9 or 10% in Crohn's disease. So it's not super high. It doesn't mean you're definitely going to get it if you have a family member who has it. And but what it is in terms of what causes IBD, I guess, like, it's not entirely fully understood, but it's thought to be a combination of factors, like complex factors that all come together to create the perfect storm to trigger the disease. And then once it's been triggered, then you have it for life. So you have a genetic predisposition. So in your genes, you have the predisposition to have IBD. You also have a disordered immune response. So your immune system is behaving in a way that it's not meant to. And then you've got the gut microbiome, so changes in the makeup of the bacteria and things that live within the bowel. And then you've got environmental factors that come in as well. So you've got things like diet and smoking and stress and antibiotic use and mode of delivery when you're a baby, and lots of other factors in your environment, urban environment, etc., that all come together to create the perfect storm to trigger the disease. So it's complex.
Yeah, definitely. And what about the diet? So obviously talk about nutrition a bit as well. There are some diets, you mentioned like a low fiber or low residue diet as well for IBD. What are some of the things that people can try or might have read about?
Yeah, absolutely. So there's lots of different diets out there that might be promoted for IBD. And I guess the most important thing to say is, unfortunately, there is no one size fits all when it comes to diet. So it's not like when you get treated with a medication, it's like, this is this for you, and we know that will do that. It's not the same with diet, unfortunately. What dietary approach is, the dietary approach that is appropriate for you will depend on the type of IBD you have. So do you have Crohn's? Do you have ulcerative colitis, or do you have microscopic colitis? Also, it will depend, are you in a flare in that moment, or are you in remission? Because the approaches are slightly different. And also, what symptoms do you have that we're trying to manage as well? But certainly the main aim of the game when it comes to diet is to make sure that someone's diet is as wide and diverse as possible and is nutritionally adequate. So providing your body with everything that it needs to function, because we do know from the research that if someone is malnourished, then they may fare worse with the disease. There may be an increase in hospitalizations and an increased surgery risk as well. So this is where diet plays a really, really important role in the management, not only of symptoms, but also in terms of the disease and disease progression. So in terms of, I guess, the different types, so kind of overall, we're looking at a healthy, balanced kind of Mediterranean style diet, and that we adapt that in a flare to help to improve tolerance. So a really practical example of that is that in remission, hopefully you should be able to enjoy things like nuts and seeds. But when you're in a flare, when there's active inflammation, actually having smooth nut butters instead, having ground nuts like ground almonds instead of whole almonds, can really help people to manage their symptoms while still enjoying those foods and benefiting from them nutritionally when they're in a flare. And then I guess also at this moment, if anyone here's listening and they have IBD and they may have been given advice at some point, it may have been years ago, but it may have been quite recently, that a low fiber diet is the right thing for IBD. That's outdated information now based on all the evidence and the research that we have about what we should be doing with IBD now. So yes, adapting those fibers and textures in a flare, like I said, use that example, can really help to improve your tolerance of foods during a flare, but completely cutting out fruits and vegetables and all of those things is not the right approach to do, not only for your overall health, but actually for symptom management and for the disease overall, because we know that a diet actually that contains fiber may actually be protective and may actually help to reduce your risk of flare-ups when you have the disease. So that's the kind of like overarching, but there are specific diets that may be helpful for specific patients. So if there is someone that has IBD and they're in remission, but they're still getting lots and lots of symptoms, they would be termed more kind of IBS type functional symptoms. And in which case, IBS style interventions might be helpful in that situation. So we'd always do all the baseline things, but then if that's not working, then we might think about something like a low FODMAP diet to try with that person. And that's got some evidence that it can be helpful when people are in remission. But the low FODMAP diet is not appropriate for someone to use to help to manage the condition or to reduce symptoms when you're in a flare. And then with Crohn's disease, there are a few more options that are really effective in terms of actually kind of treatment options. So liquid diets, something called enteral nutrition, is something that's used in Crohn's disease. So these are specially formulated. So these aren't like smoothies you make at home. These are like specially formulated medical powders that you are prescribed. You can only get them on prescription. And in Crohn's disease, we see in pediatric Crohn's, so in children, that rather than steroids, they actually give this liquid diet. So these liquid shakes basically completely replace a child's food intake. And that is really effective at helping to get a patient into remission when they have active Crohn's disease. It's not the same in ulcerative colitis, unfortunately. But actually, I've seen quite a few of the London hospitals and quite a few of my dietetic colleagues actually using it with adults as well. So either to help someone to avoid steroids or to, if they're changing medications, again, to help them avoid steroids, actually using the liquid diet. But what we tend to see is that generally adults don't want to give up eating food and just drink liquids.
Are they nice? Like, are they palatable or are they horrible shapes?
They're okay. And there's many more different options now than there used to be. They're not the most delicious thing. And I think patients often get a bit taste fatigue because some of them only have a few flavors. So maybe you have like strawberry and banana and chocolate and vanilla, and that's kind of all you live on for the whole time. But there are also some other options. There's a company now doing some savoury ones as well. If someone is really motivated and they are happy to give up food, maybe they're not really finding food that enjoyable anyway, and they want an option that's not steroids, that's definitely an option for people with Crohn's disease. So, and then there's other iterations of that. So you've got partial liquid diet, partial diet. So there's lots of approaches. But it just totally depends on the individual and what they're coming with. So, yeah.
Yeah. I guess they're properly, everything's broken down as well. It's not like just having Huel or some sort of like protein shake as a meal replacement like Slim Fast. That's not quite the same, is it, as having these like proper nutritional drinks where everything's pre-digested?
Yeah, and it's actually also, it's nutritionally complete. So those Huel drinks or any of the other kind of weight loss ones, they don't provide all your nutrition if you don't also have food. So these specifically like medically formulated ones, they provide all of your nutrition that you need for your body to function just in the liquid drinks. So yeah, things like Huel or homemade shakes or anything just cannot be used as a substitute. Otherwise, you'll be causing many more problems than you're solving.
Yeah. And are there any sort of nutrients that people tend to be low in, either because of the inflammation patches or because of like typical food restrictions that people will do to manage the symptoms, like with IBD?
Yeah, definitely. So undernourishment and malnutrition is something that's really common in IBD because and for the reasons that you said, so it's either food intake, so maybe a lot of people restrict their diet quite heavily to try and control their symptoms, which is really understandable, and I totally understand why people do that, but it's not that helpful in the long run. Or people maybe they haven't been given the correct nutrition advice, or they're getting lots of advice online, which is often the advice online is very restrictive. So don't eat this, don't eat this, don't eat this in lots and lots of different places. So that's really common in terms of food intake, but also nutrient absorption can sometimes be an issue as well. So actually when the food's gone in, is it being absorbed correctly? But that's only an issue in Crohn's disease that affects the small intestine. So I see loads of patients with ulcerative colitis coming to me and saying, I feel like food moves straight through me. I'm so worried that I'm not getting the nutrients I need and I'm not absorbing anything. And it's actually reassuring, really reassuring to be told, no, we don't need to be worried about nutrient absorption for you because your small intestine, which absorbs all of the nutrients, is actually completely unaffected by the disease. So you should be getting everything that you need from them. But with Crohn's disease, we need to be understanding where is the inflammation that's affecting you and how might that be affecting different nutrients. And the small intestine is like a little factory conveyor belt. And at different moments along that conveyor belt, different nutrients are taken off and absorbed. So where the inflammation is will affect what nutrients we might need to be considering and focusing on.
And when those patches come back to life, can people then get that nutrient absorption back, or is it that it's damaged? And
yeah, so sometimes it's what we would term transient. So people have difficulty absorbing those nutrients when there's active inflammation, but then when the inflammation is under control and they're in remission, then they do a bit better and they can absorb those foods a bit more. Sometimes though, we can get things like scar tissue, which means that then changes the lining of the bowel, and that means that the surface area for absorption of those nutrients is just less. So they're all things that need to be taken into consideration as well. And there's some particular nutrients as well that we commonly see. So iron deficiency and iron deficiency anemia is really common in people with IBD. Vitamin D deficiency is also really common as well. And then if you have Crohn's that affects the last part of your small intestine called the ileum, then we see vitamin B12 deficiency quite commonly as well.
Great. Oh, I was just going to ask a bit about microscopic colitis as well, because it seems to be like the lesser known part of IBD that people haven't heard of. And I've heard it sort of takes a lot longer to identify as well, because is it right that some of the inflammation markers aren't quite as apparent or high in microscopic colitis?
Yeah, definitely. So it is one that sometimes people wait a long time to be diagnosed for, and it's really unpleasant. Basically, microscopic colitis causes really, really watery diarrhea, and you can be going to the loo multiple times a day and feeling really not very well with it. And what you might sometimes find is that on your blood tests that things will look normal. And even on those stool tests, looking at the inflammation in the stool, that might actually come back as normal as well, or maybe just ever so slightly raised. To go one step further, if you've had a camera but they haven't taken biopsies, again, it's kind of in the name, microscopic. So the inflammation is so small and not easy to see with the naked eye on a scope. So it's really important that biopsies need to be taken so that then they can be looked at under the microscope. And that is the way that microscopic colitis is diagnosed. So my advice would be that if you've been diagnosed with IBS-D, IBS diarrhea, or you've got lots of diarrhea, and particularly if you're things like you're waking up in the night to pass a bowel movement, and microscopic colitis is most commonly diagnosed between the ages of about 50 and 70, but it can also be diagnosed at other stages of life as well. So if you're waking up in the night to pass a bowel movement, if you've got weight loss or you've got really severe symptoms, maybe it's worth asking whether they've considered something like microscopic colitis, but understanding as a patient that you'll have to advocate for having a scope with biopsies to rule that out.
Great, thank you. Wow, I think people must feel so relieved and sort of reassured when they come to you, because you just know everything and it's all very calmly explained. So,
well, I hope I haven't bamboozled everyone with loads of I try and make it as easy as possible to understand, but there's so much information to try and get across.
Yeah. Well, is there anything else that you'd like to sort of share with people who think they've got IBS or maybe haven't had all these different investigations, just to sort of, anything we haven't covered that you think is really helpful for people to have in the back of their minds?
Yeah, definitely. I think, so I guess the first thing is, coming back to what I said earlier, is if you are experiencing symptoms like bleeding when you go to the bathroom or lots of unexplained weight loss, and you're really not feeling very well at all, really don't be afraid to advocate for yourself and to go to the doctor and to ask for a second opinion and to push for more tests, because it may be that there is something underlying going on there and that needs to be investigated a bit more. So definitely don't be afraid. You're never an annoying. Some patients think oh, I'm being so annoying. You're not being annoying. You're advocating for yourself, and that's going to be so important for your health in the long run, and you'll never ever regret pushing for those tests. So definitely don't be afraid to do that. And then I guess from the dietary perspective, what I so often see patients still being told, unfortunately, by consultants, and by some consultants don't, is that they might be told when they're diagnosed, if they ask about diet, they might say, oh, well, diet doesn't matter. Just take the medications, diet doesn't matter. And I think hopefully I've described a little bit and alluded to a little bit during this conversation that diet is absolutely a vital piece of that puzzle in terms of care, not only to make sure, diet's vital for everyone, no matter whether you have IBD or not, to live a healthy life and reduce our disease risk. But when you have IBD, it can really help you to manage your symptoms, really help you to manage the condition. And I definitely see patients where it can be the difference between surviving and thriving with the disease and really living a full life with it. So definitely don't take, oh, diet doesn't matter as a given. It definitely does. And I see that in clinic with my patients all the time, every day.
So it's not diet doesn't have anything to do with it. So off you go and just eat, chips and ice cream, and it's not going to make any difference at all.
Yeah, and that's not the approach, because it absolutely can make such a difference, and it can be so pivotal to someone.
Yeah, amazing. Thank you. So where can people find you in your clinic online? And do you see people in face-to-face as well, actually?
Yeah, good question. So my clinic is virtual. It has been since COVID. So all of my patients I see on Zoom call. And so as a result, I actually see patients all over the world. So it doesn't matter where you're based. I'm based in London, but I see patients all over the UK, from Scotland all the way down to Devon and Cornwall. And I also see patients all over the world. So I currently have patients in New Zealand, Australia, the UAE, America, and dotted over Europe as well. So it doesn't matter where you are, I can help you. And in terms of where people can find me, I have a website, which is NALM, so NALMclinic.com. But I also am as active as I can be on Instagram, and that's Clemmie Oliver Nutrition. So they're the two best places to find me. And you can find information about how I can help and appointment options on my website, and you can also book through there as well. Or if you're not sure whether I can help you, you can always book an inquiry call with me for free to see, and for us to get to know each other and see how I can help.
Great. Well, I will put all of those links in the show notes so people can get hold of you. Yeah. Thank you so much. That was really good. Thank you, Clemmie.
You're very welcome. Thank you so much again for having me.
Really helpful to give a little overview of IBS and IBD and what kind of things you can look out for. Do go and check out her clinic, and I'll put the link in the show notes if you want to follow that up. But I will leave it there for today. Thank you so much for listening to this episode of the Inside Knowledge for people with IBS. Better digestion for everyone.